When caring for any patient, airway management is your first priority. If the patient cannot breathe adequately, no other treatment will matter. Always begin by assessing the airway patency and ventilatory status as part of your primary survey. If the patient is conscious and speaking clearly, their airway is likely intact. If they are not speaking or showing signs of respiratory distress, such as stridor, gurgling, or silence, immediate action is required. For patients with altered mental status, be alert for airway obstruction from the tongue, blood, vomit, or secretions. Positioning is critical. Use a head tilt chin lift unless trauma is suspected, in which case use a jaw thrust. Start with the basics. Open the airway manually and suction as needed. Use an oropharyngeal airway, OPA, in unconscious patients with no gag reflex. For patients who are semi-conscious or have a gag reflex, use a nasopharyngeal airway, NPA, if not contraindicated by facial trauma. If the airway is still not adequate, escalate to bag valve mask ventilation with high-flow oxygen. Always maintain a proper seal and ensure chest rise with each ventilation. Two-person BVM technique is preferred if resources allow. Deliver oxygen based on the patient's condition. For critical patients, use a non-rebreather or BVM with 15 liters per minute. For patients with chronic respiratory conditions, titrate to maintain an oxygen saturation of 90 to 94%. Avoid hyperoxia in certain situations like stroke and post-resuscitation. If basic measures are inadequate and the patient cannot maintain their airway or is unconscious with a GCS less than 8, consider advanced airway placement. This may include endotracheal intubation, supraglottic airways, for example, King LT, iGel, LMA. Always pre-oxygenate if possible. Use proper technique and confirm tube placement with waveform capnography as the gold standard, bilateral chest rise, lung sounds, and the absence of sounds over the stomach. If intubation fails after 2 attempts or the patient deteriorates during attempts, go to your backup airway plan. Insert a supraglottic airway, continue BVM ventilation. If all else fails and the patient cannot be ventilated, consider cricothyrotomy or needle crick per your scope and protocols. Remember, oxygenation is more important than intubation. Never delay oxygen delivery to pursue a difficult airway. In trauma patients, always maintain cervical spine precautions during airway procedures. Use a jaw thrust and keep the neck neutral. If necessary, remove the front of the cervical collar for intubation, while another provider manually stabilizes the head and neck. Pediatric airway anatomy is different. Use age-appropriate equipment and avoid overventilation. Obese patients may require ramped positioning to optimize airway access. In cardiac arrest, minimize interruptions in chest compressions. Use supraglottic airways, or BVM, early, and delay intubation until compressions are optimized. Monitor for gastric insufflation, especially if ventilating with a BVM or during CPR. After placing any airway adjunct, continuously monitor capnography. Reassess for proper placement. Watch for signs of deterioration, dislodgement, or obstruction. Your report should include indication for airway intervention, devices used, number of attempts, confirmation methods, patient response. Summary: airway management is a critical, life-saving skill. Start simple, escalate only as needed, and always prioritize oxygenation. Maintain spinal precautions when necessary, confirm tube placement rigorously, and reassess continuously.